So if you have been doing medicine for a while, or if you have been studying medicine for a while, been practicing for a while, then you must have heard about pheochromocytomas, and you probably know something about them. But if you don't, it is very fine, because in this video I'm going to cover both the basic facts pertaining the tumor, and I'm also going to advance or talk about some of the advanced things that are associated with pheochromocytomas. Welcome to Med1 page. My name is Benjamin, and let's look at the pheochromocytoma. So to begin with the definition, pheochromocytomas are neuroendocrine tumors that arise from the chromaffin cells. And when we talk about the neuroendocrine, these are tumors that are associated with, when we talk about the word neuroendocrine, you see we have neuro, we have endocrine. Neuro is to do with the nervous system, and endocrine is to do with the endocrine system. So most of the time when you have cells from this origin, your endocrine cells, they're going to be communicating between the nervous system as well as the endocrine system. So when you look at things like hormones that are triggered by the nervous system, like the hypothalamus, like things like that, like the catecholamines, epinephrine or epinephrine. So what happens is that we have the adrenal medulla, and this is the area in the adrenal gland that is at the core and is responsible for producing these catecholamines. So these catecholamines are going to be epinephrine, dopamine, and most of the time these ones are the hormones that are responsible for the fear of flight response. So once you see something and you get scared, your body is going to communicate with these endocrine glands, and they're going to produce the catecholamines. So the chromaffin cells are the cells that are responsible for producing these catecholamines in the adrenal medulla. So what happens is that we have a tumor of these cells, so we have abnormal proliferation of these cells, and they're going to produce these catecholamines without regulation or without instruction from the brain. So what happens in the pathophysiology is that when the catecholamines are produced, that is epinephrine and dopamine, we're going to have a catecholamine excess. And the catecholamines are going to act on different receptors in different target organs. So the alpha 1 receptors are the ones that are found on the blood vessels when the catecholamines act here. On the alpha 1 receptors, we're going to have vasoconstriction. So when we have vasoconstriction, we're going to end up with a hypertension. Then they're going to act on the beta 1 receptors that are found on the heart, and shall have a tachycardia as well as arrhythmias. Then it will act on the beta 2 receptors, and that is going to cause a tremor, it's going to cause anxiety. And when it goes to the pancreas, we are going to have hyperglycemia, because there will be suppression of that production of insulin. Because look at this, when you're having fear, or when you are needing to respond, or you have high levels of epinephrine, you don't want your muscles to look for the glucose. You want the blood to have as much glucose as possible, so the muscles can take it up and enable you to give the appropriate response. So hyperglycemia is going to be what is going to be seen. Then the tumor is going to secrete these hormones in a way that may be continuous, or it can be episodic, what we call the paroxysmal release, called paroxysms. So when you look at the epidemiology and the natural history, it is that pheochromocytomas are quite rare, but they can be lethal if undiagnosed, and they are able to occur in any age, including the neonates. In the pediatrics, the condition is most likely going to be genetical. It's going to be, they may be extra-adrenal, where we are not going to find these tumors. We're going to find these tumors outside of the adrenal blood. Most of the time, when they're outside the adrenal gland, we don't call them pheochromocytomas, we call them paragangliomas. Then most times when we have these undiagnosed tumors, they're going to be a major cause of perioperative sudden death. Someone goes in for a surgery because they have this increased level of catecholamines, they get hemodynamic instability during the perioperative period, and then they die. So when you look at the embryology and the tumor biology, is that we have the chromaffin cells that are going to come from the neurocrest cells, and they are going to migrate. And during migration, some of them stay in extraadrenal areas, and they will form what we call the extraadrenal paraganglia. These extraadrenal paraganglia are going to be assuming the function of the adrenal gland as before it matures. They're going to be producing these catecholamines and things like that. But after birth, they're supposed to regress. And if they persist, they're going to form what we call the paragangliomas. And these paragangliomas are going to produce those hormones, norepinephrine or dopamine, as you can see. But we need this hormone, the PNMT enzyme, that is required for epinephrine synthesis. So to convert the norepinephrine to epinephrine, you need this enzyme. And this enzyme has special requirements in that it requires an area with a high local cortisol. The area should be having cortisol for it to work. So it is not a coincidence that we only have cortisol in the adrenal gland. So the adrenal medulla is the one that is going to have high levels of cortisol. So because the high levels of cortisol are only in the adrenal gland, the PNMT enzyme is going to work here, and therefore only pheochromocytomas are going to be capable of producing epinephrine. If it's the paragangliomas, they are not going to be able to produce that epinephrine. So that's going to explain why adrenal tumors are going to produce epinephrine, but the extra-adrenal tumors are never going to produce epinephrine. They will just produce only norepinephrine, and then dopamine can be produced by either tumor. So when we look at the genetics and the molecular pathways, we're going to divide them into two functional clusters, and that is cluster 1 and cluster 2. Now, I know this is a lot to take in, and the genes will always be disturbing to remember, but I want you to remember the Van Hippel-Lindau and the SDH, the SDHB. So when you look at Van Hippel-Lindau and SDHB, these are going to be high, they're going to cause increased signaling of the IHF, and this is going to cause angiogenesis. So what basically happens here is that when you have the SDH mutations, they're going to activate the pseudo-hypoxia pathway. So the body assumes you're having an area of hypoxia or something like that. And how the body is going to respond, it's going to be doing things like angiogenesis, and except that we are not actually experiencing this problem. So what happens is that the tumor is going to be very, very, very effective. It's going to have a high survival rate, and that is going to increase its malignancy risk. So these pheochromocytomas, the synergy with Van Hippel-Lindau as well as SDHB mutations, are going to have very, very, very higher rates of malignancy. Then the cluster 2 is where we have the RET gene and the neurofibromatosis 1, the MAX, as well as the TME127. And these ones are from the kinase signaling pathway, and these ones are going to be less malignant. So remember always the RET gene is associated with men, and pheochromocytomas are going to be found both in men 1, in men 2A, and men 2B, not in men 1. So remember these two pathways. Remember, whenever you are thinking of a highly malignant pheochromocytoma, that is the Van Hippel-Lindau as well as the SDHB pathway. If it is the non-malignant one or the less malignant one, think of the RET gene in men 2, as well as neurofibromatosis. So the practical rule is that all patients that are less than 45 years old, we need to consider doing genetic testing if they are having this, because this means it's occurring earlier than expected. No most cancers are going to occur in the elderly. So we're having a tumor occurring earlier than expected. It's most likely going to be coming from a genetic origin. Then, whenever we have bilateral pheochromocytomas on both adrenal glands, then it is genetic until proven otherwise. And this SDHP mutation, you need to do lifelong surveillance of this patient. Even after you do surgery, there's a high risk of recurrence and a high risk of malignancy when it comes to pheochromocytomas caused by this condition. But look at the clinical presentation. We're going to have the classic triad, and that is the episodic headache, sweating, as well as palpitations. Then when we look at the other clinical presentation, can be in terms of cardiovascular complications. These people can have what we call catecholamine-induced cardiomyopathy. They can have Takotsubo cardiomyopathy, which is also called the broken heart syndrome. They can have myocardial infarction, even with normal coronary arteries. They can have aortic dissection. And metabolic effects, they can have hyperglycemia due to decreased insulin secretion because of activation of the beta 2 cells. They can have weight loss, again, because of decreased insulin. And boom, they can experience lactic acidosis, but this is a rare manifestation. So when you look at the hypertension in these patients, sometimes we're going to have paroxysmal kind of hypertension where we have episodic crises, but with a normal baseline. Someone normally has a normal blood pressure, but all of a sudden they get this high blood pressure, then they go back to a baseline, which is normal. Then we have a sustained where they have a constant hypertension all through. Then we have the mixed where they have a sustained hypertension, but then they even get and a sudden increase, which is a paroxysmal. So these are 3 types of hypertension that are found in people with pheochromocytoma, and this is very important for exams. Then we have some special scenarios like in pregnancy. When someone has pregnancy, most of the time you have high maternal and fetal mortality rates, because if this patient goes into labor, most likely they're going to have release of catecholamines. It's going to lead to instability, and most of the time, even the fetus, they're going to experience spontaneous abortion. So during these patients, most of the time, we don't encourage normal delivery, and almost of the times, the cesarean section is done as soon as the fetus is able to attain fetal maturity. And sometimes during the cesarean section, if it's possible, the pheochromocytoma may be removed. If not, we can do it in the postnatal period after the mother's given birth. Then MRI is the preferred method of investigation here in pregnancy, and surgery can be done to remove the pheochromocytoma without interrupting the pregnancy if it is earlier than the second trimester, as early as the second trimester. Then we have incidentalomas. So an incidentaloma is when you do an imaging for a totally different reason, but then you find that you have an adrenal tumor and you don't know what the tumor is all about. You don't know, is it producing hormones? Is it not producing hormones? Is it producing catecholamines? Is it producing sex hormones or anything like that? So whenever you find an incidentaloma, before you do a biopsy to find out what kind of tumor it is, please rule out of your pheochromocytoma, because the moment you go and manipulate this tumor in any way, there's going to be a release of catecholamines, and that can lead to hemodynamic instability. Then we have dopamine-secreting tumors. These ones are often going to be normotensive patients that are going to have high blood pressures, but it's going to be more aggressive. And most of the time, whenever we have tumors producing dopamine, these are the tumors that are most likely going to be malignant. And they're going to have elevated plasma methoxytyramine, and this is the end product from the breakdown of the dopamine. So when you go to the screening tests, most of the time, or the diagnostic tests, most of the time, you're going to do the plasma-free metanephrines. And these ones are going to have a sensitivity of 96 to 100%, the specificity of 85 to 89%. So there are some things that can actually influence the amount of metanephrines within the plasma. Things like maybe caffeine, things like antidepressants, they are able to alter the amount of these metanephrines. But the urinary metanephrines are highly sensitive, with a sensitivity of greater than 98% and a specificity of greater than 98% also. So whenever you're faced with a situation where you're told to choose between plasma metanephrines and urinary metanephrines, go with the urinary metanephrines. Then the imaging, you can see on a CT most of the time, characteristics are not very good, but you have the 10 Hausfeld units attenuation, delayed contrast washout, and then central necrosis is also very common. Then on the MRI, it has a characteristic feature, which is the tight brightness on T2, and then you have low voids due to the vascularity. You can do nuclear imaging with the virodoxyglucose PET scans, that's for aggressive tumors, the gadolinium data-TET PET scans, that's for the SDH, the SDH rated tumors, and then many other imagings are very used. These ones are not very common, are going to be asked on your examinations, but I will always refer to the current guidelines when it comes to such important clinical decisions. So the first thing you want to do is that you want to normalize the BP with alpha blockers, that is phenoxydenazamine, and that you're going to do this 7 to 14 days before you actually begin doing the surgery. And then you want to introduce beta blockers only after they have had adequate alpha blockade. And this is because as you remove the alpha stimulation that was being done by the catecholamines, the heart may try to compensate because the intravascular volume is going to be low. So as you do this, the patient is going to experience this it's a more of a reactive tachycardia. So you want to stop that tachycardia, you're going to give a beta blocker, that is propranolol 10 to 40 milligrams. Then as you are normalizing the BP, or as you are doing the alpha blockade, you have to make sure that you are replacing the intravascular volume. You want to give them fluids as much as possible, because these fluids are going to help, because previously they had constricted vessels, and as you dilate them, the blood pressure is going to fall. So if you do not go on and replete that, they may end up going into heart failure. So you want to restore their traversal volume as much as possible or as good as possible. That sometimes nicardipine alone has been used, and it shows similar efficacy to when you use the alpha blocker as well as the beta blocker together. Then we have seen drugs like the methyl P1 tyrosine, which is metyrosine, and this one, this interferes with the production of catecholamines. And it has been found that when you use it prior to the surgeries or during this preoperative period, you reduce the amount of catecholamines, then you have good stability during the period of the intraoperative period. Then you want to prevent intraoperative catecholamine crisis, and this is going to begin with the surgical technique. You don't want to manipulate the tumor in any way. You don't want to rupture its capsule. You want to be very careful. You want to remove it and blow the whole of it. But sometimes you still have this hypertensive process occurring, and you want to use drugs like IV ventolamine, which is a rapid-acting alpha-adrenergic blocker, and you can also use esmolol, which is a rapid-acting beta blocker, short-acting beta blocker, and you can use this to manage when most of the time when they have the arrhythmias. Then you want to use labetalol and carvedilol. These have been used, and most of the time when you use labetalol now in patients that are having a pheochromocytoma, most people will argue that labetalol is also an alpha one. It's an alpha and beta blocker, so they will think I can use labetalol alone. But actually, what happens is that if you use labetalol alone, labetalol is more potent as a beta blocker. So if you use it, you won't have adequate alpha blocking, and then you'll have this paradoxical hypertension, whereby you are using an antihypertensive drug to give to reduce the blood pressure, but the patient's blood pressure keeps on shooting, and this is because there is no alpha blockade. Then there's no alpha blockade, and you're also blocking the beta 1 receptors, and this is going to cause that increased blood pressure. Then we have the selective alpha 1 blockers like doxazosin. These ones have been found to have less side effects, and most of the time if a patient has inoperable, or they're inoperable, or they're going to need these medications for a longer time before the tumor is removed, then you can choose to use those ones. So we have the recent criteria. This is the criteria that was used long ago to determine whether the patient has been adequately alpha blocked, and it would tell you whether the patient is ready for surgery. So what you would do is that you check and make sure you have no BPs that are greater than 160/90 within 24 hours of the surgery. They have to have no orthostatic hypertension less than 80 to 45, and there are no ST to T changes. There's no ST to T changes for 1 week, and less than 1 premature ventricular contractions every 5 minutes. So the surgical strategy, the key principle is that you want to do early venous ligation. Remember, there's only one vein that drains the adrenal gland, and that vein is the one that is going to contain all the secretions from the gland. So you want to do early venous ligation. You want to do minimal tumor manipulation, and then you want to do en bloc resection if invasive. That means you want to remove everything that's associated with the tumor. Then other piles are like, you may need to use isoflurane and enflurane. These ones are preferred because they have minimal cardiac depressant effects. Fentanyl, ketamine, and morphine may stimulate catecholamine release, and therefore may be avoided during that period of anesthesia. Then when you look at the tumor size, if a tumor is less than 5 centimeters, sometimes you can opt for laparoscopic approach, and whenever it's greater than 6 centimeters, you want to go open. Then if it's malignant, you also want to do an open surgery. Then if you're genetic and bilateral, sometimes you can do the corticospiraling, where you remove the adrenal medulla and leave the cortex such to avoid the patient going into a Addisonian crisis or requiring steroids lifelong. But even most of the cases, the patient still will require steroids lifelong. It may not be successful. So postoperatively, you want to monitor for hypertension. You want to monitor for hypoglycemia because of rebound insulin production. Remember that not be producing insulin because of the beta 1 stimulation, and now it's gone, the beta 2 stimulation. So they may produce a lot of insulin, leading to hypoglycemia. A lifelong, you want to continue screening for plasma urinary metanephrines to see if we have a recurrence or nothing of the sort. Then genetic cases, you want to do imaging every 1 to 2 years. So when we look at the malignant chromocytoma, it's going to occur in 10% of your chromocytomas. And the key fact is that malignancy cannot be diagnosed histologically. When you look at the malignant as well as the benign pheochromocytoma, histologically, they're going to look very, very identical with similar characteristics. But we have some characteristics that sometimes ring, or that ring an alarm and suspect that maybe we have a malignancy going on. If the tumor is greater than 5 centimeters, you suspect it is if it's greater than 5 centimeters, it's a pheochromocytoma, you suspect malignancy. For paragangliomas, greater than 4 centimeters, if there is gross large vessel invasion, suspect it's mostly going to be malignant. If it has the SDHB variant, this gene mutation, then you suspect malignancy. And if it's secreting dopamine, or there are high levels of the metabolite methoxyteramine, then you suspect it could be malignant. So emerging therapies for malignancies, we have the tyrosine kinase inhibitors, the IHF1 2 alpha inhibitors, and the peptide receptor radionuclide therapy. All these are things that are being looked at. Then the prognosis, benign tumors, the prognosis is normally excellent. For malignant disease, where survival rate is not so good, it's 40 to 60%. It's actually good. Then look at those spots. Then early detection is going to dramatically improve the outcomes. So what you should remember for exams or clinically is that never biopsy an adrenal mass for ruling out whether it's a pheochromocytoma. Then beta blockers alone are going to be a death sentence. You have to make sure you have alpha blocked this patient before. Then normal metanephrines. When you have normal metanephrines, most of the time pheochromocytoma is excluded. So metanephrines are a very, very big thing. Then the SDHB is the one that is mostly associated with malignancy. And then when you have a patient with hypertension and surgery, as a death during surgery, always think it could have been a pheochromocytoma. Thank you for watching this video. My name is Benjamin. If you did ever enjoy this video, please share it with a friend. Leave a comment, leave a like, and check out my short video I made in the section about sheds. There's a video I made about the 10% rule about pheochromocytomas. Please check it out, because it is one of the most important clinical aspects when it comes to pheochromocytoma, the rule of 10. Thank you very much. My name is Benjamin. Have a nice day.